See you? Yes. So perfect. It's a pleasure to be here. We are here in operating theater with Vincenzo Sarnicola doing a case on a patient that we are going to give the details in a moment. Before to start, I would like to thank you, Professor Giannacre, to host the SICSSO 2026 live surgery today, and in Policlinico Universitario di Cagliari. Here we are in the theater and we are starting now. So just to tell you what we are doing at the moment, there is the case is a patient with 45 years old, contact lens wear, female, that in her left eye had in 2024 an infection that in the beginning, as you can see from the slide, you will see this infection 2024 as a big infiltrate and hypopium with the swelling of the cornea. Then with the next slide, you will see in a moment, exactly, she was treated at the beginning with antibiotic treatment, and then also some steroid drops and some oral acyclovir. So there was no make the diagnosis until it came to in this setting where they started Acantior, and was carrying on this Acantior for 6 months and was able to cure the problem. However, left some scar, as you can see here, corneal neovascularization, and after a year, you can see here the images. There is an important thinning of the cornea that is mainly in the center and infratemporal. It's getting very thin in the center is 182, as you can see from the slide. So Professor Sarnicola, what he did at the moment, as you can see, can you show us the exactly? So Professor Sarnicola marked the thinner area, so the edge of the thinning of the area, and then he marked the periphery where he's going to do the trepanation. The trepanation, which is the size of the trepanation, is 8 millimeter, 875 millimeter. So it's 875, and it's a partial trepanation. As you can see, he, with the guidance of the OCT, of course, is doing this trepanation with the trepine manually. There is no guidance. Then now you can see here there is a mark in the periphery. It's getting a little bit more difficult because the periphery, as you can see, is 279, and so the trepanation he will have infratemporal, a little bit of thinning of the cornea, where it will be a little bit more challenge. So here there will be a debulking. However, because in the center is a little bit more thin, will be a little bit more thin, means 182, as you saw before from the slide, can be a little bit dangerous to do that. So we are going to just do a dissection, debulking in the periphery, without go to the center, in order to reduce the risk of any complication. And so, for this reason, the mark of the periphery of the thinner area helped a lot. So, it's quite important to see, first of all, here, that it's very important that the diagnosis needs to be right since the beginning, otherwise the scar is a little bit more important. And also, the thinning, it's very thin. This makes the surgery challenge, but also, this shows you that probably an early diagnosis, an early treatment probably could be benefit for this. So benefit because now it's extremely thin. The cornea, the first third of the cornea is gone, and so it's now she needs a surgery. So doing a lamella surgery is very important here because, of course, we all know that it's infectious cases. We all know that it is being neovascularized, that there is a little bit more risk. For this reason, so what we have tried to do here, just to expose the periphery and try to do what is peeling off technique. Peeling off technique, why? Because there is more chance that, less chance of complication, of course. And you can see here what it's doing. So he did a peripheral dissection, as I said before, and now he's trimming this anterior part of the peripheral cornea where there is more thickness of the cornea, let's say, and doesn't go in the center where it's extremely thin. And then is going the periphery in 8.75 periphery to create in a spiral way, let's say, in order to do the peeling off. The patient, just to come back to the patient is in general anesthetic, and here we are having the peripheral dissection, as you can see. The patient is phakic, 45 years old, as I said, and the fact that we wait a year after, this make better the possible complication, because of course you need to wait a little bit in order to avoid any kind of recurrence of the problem, or you make sure that there is no any more cyst. Now, of course, can you hear Professor Sarnicola? Hello?
Hello?
Oh, we can hear him.
Yes.
Okay. So I just made an incision of the tissue of the superior part that I'm sending to the pathologist to see if this part of the if this part of the tissue is infected or not, because in this way we know we are evaluating the periphery of the incision, the periphery of the transplant, sorry. And now we need to prepare this one in the inferior part. That is more difficult because the tissue is more thin. And we don't want perforate.
So it's very important. So as we saw before, the patient had this infection in 2024. In 2025 was in the end treated with drops, but we wait a year. During this year there was no recurrence. It's been done a confocal microscopy to see if there is any cysts, but now it's making to make sure that there is no more cysts. I think bringing this one to the histology, to the pathologist, I think it's helped a lot in order to see it, to make sure also that there is no any more tissue in the periphery that is outside, let's say, of the thin area, outside of the scar, outside where the cornea was more affected. It's important because this could be something that to know, to start the treatment, because we are going to start some steroid treatment after the keratoplasty. So to know if there is any residual cyst in the periphery will be more important. And in this way, in vivo confocal microscopy plus histology, I think reassure the patient and the surgeon. And now is trimming the peripheral part, as you can see here. After that, with a spatula, a very thin spatula, is going on the edge of the trephination, of the 8.75 trephination, and is going to go quite deep. As you can see now, we trimmed the other part, and we are sending for histology as well. Exactly. Okay. That's it.
Okay, ora paracentesi.
So, as you heard from Professor Sarnicola, is doing a paracentesis. The paracentesis is made with a 1.1 knife, as you can see here, in order to reduce the pressure in the anterior chamber and to avoid, again, any complication. In this way, the eye is more soft, and it's difficult that you can have a problem in the periphery. Make it a little bit more hard to find the thinnest, the deepest plane, but it's less complicated. As you can see here, this is the spatula that is with the soft tip. Soft means a roundy tip, and it's going to look for the deepest plane. So with this instrument on the right hand and on the left hand, here's a forceps, a corneal forceps. He's trying to go to the deepest plane in the periphery, and then he will follow a spiral pathway. As you can see, this dissection is blunt dissection. It's going to this movement right to left in order to gain space and going deeper. Going deeper. For this reason, as I said, if you go 360 and you go in the spiral way, you will find probably yourself to go deeper and deeper, and to find the right plane in order to do the peeling off technique. As you can see, he just wet a little bit and then he dry over, because in this way it's the dry over was easier to get the vision, and at the same time you don't want too dry because it can break more easily, especially in these cases where there is in effective cases a little bit different compared to the keratoconus one. So you already gained a deeper place in the periphery. Is going to cut with the scissor. This scissor has let's say, a blunt edge as well, in order to avoid to reduce any complication. As you can see, that is quite deep already. And I think he's going to do this movement in 360 degrees. Can go from one side and to the other. As you can look here, it's like, say, a waist blunt dissection. And normally, more deep you are, more easily will be the blunt dissection. And it's a kind of good feedback for the surgeon. As you can see, it's quite quick going around. This means that it's in the right plane. You can see you can do probably 30 degrees or more. And then this makes everything easier. The starting point is to have a very good trepanation that is quite deep, in order to have, let's say, a good starter. The fact to remain intact the center where it's more thin is very important movement in order to avoid any risk to go over, because do a debulking of 182 micron in the center probably is just too risky for don't gain very important things, because you need the periphery to go deeper. So you can see here that he's gained more and more space and going around, and now he's doing this peripheral dissection. If you have any question from the audience, as you can see here, look, it's very easy to dissect. So the plane is is right. It's the right one. It's going very quickly in the periphery, going around, and all the tissue that we are going to take out after is going to go to the pathologist for examination, of course. So again, if you have any question, let us know. So just to back to you to the different steps. So the first steps was to sign the periphery of the teaming area. Then the second step was to mark the size of your trepanation. In this case, it was 8.75, and then do a peripheral debulking. Send to the pathologist the tissue removed, and then do a paracentesis, reduce the pressure in the anterior chamber, and then find with a blunt spatula a deep stroma in the periphery at 8.75.
Nico.
Yes.
Hi, this is Vincenzo. How are you? Can I ask you a
Well,
question?
thank you.
You mentioned pathology. I think what you mean is that you're sending a specimen to both histology and microbiology as well? You will split
So
them?
we send, pathologists, I think we send it to both I think the histology, because we expect probably to see some cysts. Probably will be difficult to grow anything after a year, but probably the histologists they are able to see something more microscopic. So it's been put in formalin, both pieces, and the pathologist with this their analysis, they are able to see if there is anything there, but it's been put in formalin. So the pathologist for me was histopathologist. Okay. So you can see that is the area that is more thin, probably the most difficult one, because as you remember the infratemporal one, where there was the neovascularization, that was a quite mature vessel, because the vessel was there, of course, for 1 year, was a little bit bigger, the area after here, but waiting a year after the resolution of the infection, this makes the vessel a little bit smaller, however, was still there. This inferior temporal part is a thinner area, and being thinner, to make this movement at the moment is a little bit more challenge. It's more challenge because the tissue is less, and then there is some adherence. As you can see here, that probably is the area is already quite thin, and probably there is not too much stroma to take out from there. These blunt scissors that you can see here, he used this blunt scissor in order to do comfortable the dissection. You see as well that the eye is quite soft. This again try to minimize the risk of any kind of risk. Now with this movement, as you can see, is gain the deeper layer, and is try to see if it is anything to go deeper, or you can probably in the right plane start a peeling off technique. For this reason, we can say that it's a spiral, because now he is coming back, as you can see here, to find a place that it's even deeper. It's even deeper, and make him easier the movement of the peeling off. So it's coming back on the stroma. As you can see, that is quite good feedback, also visual feedback, that the cornea, the bed, let's say the stromal bed remaining, is getting more and more transparent. This is a good feedback regarding the deepest plane that you are, and then probably in your end you will feel it that probably the stroma does not come as easy. For this reason, he moved to go a little bit more in the deepest plane. Now he pulled the stroma, and then he's getting deeper. Sometimes you realize that doing this movement, you don't end up to be on the to do all the round, because sometimes they are not on the same plane. But you will see that when you are in the right plane, he will come very easily, and then probably, let's say, you don't need to do 360 degree. for this spiral because it's going deeper and deeper.
Hi, hello, this is Sophie Dan. Can I ask a question?
Yes, please.
Hi, this is really beautifully done. The question is that how do you decide which techniques to use, like big bubble technique versus this peeling techniques? Is there any preference in different eyes that you pick which technique?
Yes, so discussed this before with also with Professor Sarnicola, and normally what we do at the moment as well, that in infection cases, normally we start always with the peeling off, because there is a higher chance of a complication with the big bubble, and there is also because there is some scar in the center. Also, some scar was quite deep scar. It was quite thin. So this technique of peeling off is more reliable. And I think this is the preference also. I'm saying right that it's also your preference, Professor Sarnicola, right? That is having this thing make more easy to get what we want. So we want a deepest lane, and we want to make sure that it will be a lamellar instead of a PK. You can see here that it's approaching the thinnest area, and where the thinnest area is, of course, there is more adherence. This is one of the other reasons why the big bubble is a little bit more challenged. And with this blunt cannula is going, let's say, deeper and deeper. As you can see, look, it's very deep in the nasal side, and it's quite clear. It's quite clear down there, and is making is reducing the pressure into your chamber, because he knows that going more you do this kind of movement, more you have having a low pressure into your chamber is better to minimize any issue. You can see that it's going deeper and deeper. They make a stromectomy, let's say, that it's what you want. Sometimes we are used to see the peeling off in the dark cases probably come in all one piece. In this kind of condition, sometimes it take a little bit while in terms of you need sometimes help with the blunt spatula, because you don't want to make too much traction, and sometimes you want to go even deeper. As he's doing at the moment, if you remember, we are going to this deeper and deeper with this blunt spatula all over again the same places. This is the concept of the spiral technique that Professor Sarnicola published with a big series on lamellar keratoplasty. And you can see doing this traction, you will see and you realize how deep is this, and how can you manage to be in the right lane. So he's getting some feedback with his forceps to see how it goes, and if there is any adherence. He's taking out this adherence, as you can see, and helping him to do the movement of the peeling off. That is beautiful. That is coming more and more. So he's helping to do this kind of. This was, if you remember, this is the thinnest area. This was 182 in the thinnest part. That is going from the center to the inferotemporal. You can see that it's coming out beautifully. And as I said before, sometimes you need the help with the cannula, so with the spatula, with the blunt spatula, in order to get what you want. Exactly. So just just to remember, this was so we are going from the superonasal to the inferotemporal. Inferotemporal was the thinnest part, where the one that it was more difficult to dissect because it was very thin. As you, I think you heard Professor Sarnicola say that is adding some BSS in order to have the tissue not too dry and not to, in order to make easier the peeling off. So it's getting wet and then dry, as he done before in the periphery, if you remember, and then he can again minimize the complication. You can see some part in the center, they are quite thin and beautiful, and then he's taking out most of the stroma, that is where the scar is. With the blunt spatula, is going deeper in order to take out some more stroma from there. That is the peripheral part, and this shows how adherent could be the stroma when it's inflamed and when it's scarred. And this is coming back to the question. This is the reason why probably is more reliable to do a peeling off or lamellar dissection compared to a big bubble, because sometimes it's more difficult to, having so much adherence, it's more difficult to get to achieve a big bubble, or sometimes you can get a bubble type of 2 that is quite difficult to manage. Probably it's better to, for this reason, starting with this technique. This, remember that this was the thinnest area where there was an infection there, so the adherence is quite hard. And this was also where the conionevascularization was, so inferotemporal. The patient was a contact lens wear. And this is quite important to tell them, and especially when you wear contact lens, educate the people and be aware of which kind of infection could have. So just to tell you again, the deepest plane. With this deepest plane is being sent again in the formalin to the histopathology in order to see if there is any cyst or trophozoite, but cyst remain. It's trimming the edge, and you can see that to make even in the thinnest plane is able to take out the periphery and making making a good periphery in order to implant then the donor.
I just want to say that, can you hear me? Yes?
Can you listen? Yes, yes, I can listen.
Okay, so I didn't feel strongly because tissue is, I don't know how much healthy, so I prefer to help with the spatula. But as you can see here, we are in the predeschmatic plane, it's very small. So the surgery is done. We have to put the graft now, and tomorrow we will see that the recipient bed will be less than 100 micron, probably 50, 60 micron, and this is a good result. And the prognosis of this corneal transplant is much better than a PK that probably mostly of the surgery should have done in a difficult case like this with very thin central part that is 200 micron, including epithelium. So at this moment, I just put donor and stitches, so you can go with your talks and we can connect later to speak to see the result. And if you have some question now, I can answer you.
Any questions for Dr. Sarnicola? Mark Terry wants to know if you're trimming the periphery more. A nice vertical edge.
If you are trimming the periphery more.
Yeah, a little bit, not too much.
Yes, they are trimming a little bit, but not too much.
Well, beautiful dissection. Thank you. One more question.
Does he wash the ocular surface with hair cream or something else?
How did you prepare the ocular surface before you started the surgery? Or now? You're going to wash it with anything?
No. Some water, and now I prepare the donor. Like we prepare the tissue.
Water. That's how we got this.
Sparkling water.
Okay. Do you want us to start with the
Tissue.
Yeah. Okay. Well, that was a beautiful dissection. I think at one point the whole room was holding their breath. So we're going to start with the talks. The first talk is Dogmata Femto Mushroom Dog.
Thank you very much.
See you in a bit.
Share my slides.
Can we have Dr. Mino's slides, please?
Okay, great. So, buongiorno a tutti. So I'm going to be talking about intraoperative OCT from mushroom dog. We started this technique now probably about 3-4 years ago, and I'll show you some updates on where we're using these in my financial disclosures. So many of you will be aware about the use of femtosecond lasers for keratoplasty, and it's been around for almost like 15 to 16 years, and primarily they're using them for fancy incisions, as you can see from these pictures. And the evidence in the literature will show you that you get better sort of wound healing around the edge itself, you get better acquisition and alignment, but generally, when you take the stitches out, the visual acuity results have been quite equivalent when you look at this in the long term. So if we focus a little bit more on dog, of course, there again, back from 2009, from the first publication up until 2023, you'll see there, and then in red bold over here, you see this meta-analysis in this AJO study. You can see that, of course, it's been used for dog, but again, it's making the vertical trephination. And one of the issues, basically, when you're using femtosecond dog keratoplasty, is that once you make that vertical incision with whatever configuration you want, you then have to basically put a cannula or a needle in to basically get the big bubble. And that can be one of the most challenging parts of the surgery. So back in 2018, working with Zima femtosecond laser, we helped develop this software in which you can basically use the real-time input OCT to actually put the tunnel using the OCT in the patient actually when you're doing the scanning itself. And using the low energy advantage of the femtosecond laser with this system allows you to make the tunnel within 50 to 60 microns of decimated membrane. And you can basically adjust the parameters as you can do with any laser system. And we did a whole series of cases. This was in collaboration with Theo Seiler's group in Europe. This is just basically one of the cases from our publication. So we did basically 14 cases from this initial series. We did a whole wet lab analysis basically at the same time. And we had pretty good basically follow-up. We were able to get a bubble in all cases. And you can see from this small initial series that there was perforation during the osteomectomy, but obviously you were able to complete basically the dog surgery. So once the laser has cut the tunnel, it's now cutting the vertical edge on the surface. You simply peel off the edge from the stroma, insert your basically dog cannula into the tunnel that's been pre-cut with the laser system, and then inject the air in order to get your big bubble, as you can see, and the rest of the surgery is similar to most dog surgeries as well. Now, following that publication, a few other people, you can also been able to publish using the same system, one basically using the Victor system, as you can see on top, and they're also able to get a bubble in this series of about 10 to 12 cases, 100% of the time. And Boris Mayugin, initially in Fedorov, when this publication came out in 2023, showed an improvement with the laser tunnel compared to doing a manual tunnel, and this also basically had an effect in reducing its conversion rate to penetrating capacity from 15% down to 7%. So it shows you the advantages of increasing success of getting a bigger bubble in individual series. And it's important to think about this when you're looking at your own data. Now, obviously, one of the issues with that paper was that we were doing that with a straight cut configuration. And there's many advantages now in literature, especially using a laser, to alter the shape into basically a mushroom configuration. Massimo Bustin published an excellent series of publications showing you the advantages of having that large anterior ocular surface with respect to early visual acuity outcomes itself. And because of that mushroom configuration, it can reduce the risk of basically perforation when you're doing the most difficult bit of the surgery on the stroma. And I'll show you some ways of basically understanding this. Now, if we look at two of the largest series published in the literature looking at manual dub, this is a series from SNEC on the right-hand side, published in AJO, both published in AJO, almost basically at approximately the same time. You'll see large series of cases, different perforation rates, different conversion rates to penetrating chiropractic. But the main difference with the Gene series is the series on the right-hand side from Singapore is primarily two surgeon series. The series on the left-hand side from Moorfields is multiple surgeon series itself. And it's important to look at this to understand where you want and what you want from the laser. So for us, we wanted to basically reduce our perforations down from 18.7% to a lower perforation rate. If we look from this paper to see where do we perforate, there's basically three stages, which is almost 30%. One is during the deep lamellar dissection. One is basically during the air injection to get the big bubble. In the laser system, we can basically get around these problems by having a larger anterior surface, so you're suturing well away from basically Descemet's membrane. The stalk will allow you to dissect less on Descemet's membrane, typically compared to basically a standard anterior lamellar surgery as well. And of course, we have the tunnel to basically do the air injection. But the most difficult thing is to understand how the laser can create all these movements with 3D lamellar movements and basically a tunnel itself. This gives you an idea from a concept-wise of the difference in how much time you spend dissecting on basically Descemet's membrane. With a standard mushroom, I do either 6.5 or 5 or a 6 millimeter stalk. Your area is about 33.2%. With the standard dog at 7.75 diameter, your area is 47.2%. Now, this is an absolute difference of only 14 millimeters squared, but it's a relative difference of 42%. And this is the way you can drive down your perforation risk because you're spending less time basically on Descemet's membrane when you're doing basically your dissection. So I'll show you these two cases. I mean, we have many cases from the publications, but I'll show you these two cases. One of the scar from keratoconus. The patient came to me from from Vietnam, a German guy with a post-infectious keratitis. So you can see basically it's an advanced scar with basically a central apex corneal scarring, and you'll see in a minute with the laser how we'll basically adjust basically the tunnel on the intraoperative OCT. On the right-hand side, you'll see a similar process itself. Initially, you need to mark the centration as you do in a normal keratoplasty prior to the surgery because of the fact that you need to basically know how to basically do the center because you're going to appronate with a flat appronator with the femtosecond laser. Now, the advantage of the laser is because you've got the intraoperative OCT, I can place that tunnel exactly basically where I want, and you can see I'm dropping the lamellar cut down, so it's going to cut underneath basically the scar, and then it's basically going to create the laser underneath there itself with the tunnel. On the right-hand side itself, it's already basically cut the laser system, so it's going to cut the mushroom configuration, and then all you need to do is basically peel it off from the surface. You can just where the scar is, you may need a little bit of manipulation with the Sinski hook to gently basically tease it open, and likewise basically on the left-hand side. Then all you need to do is basically get your tunnel and put your cannula in the tunnel in order to basically get the big bubble. So you can see that on the right-hand side, all I'm doing is putting the cannula, it's already pre-made, and basically just inject your air. You can use whichever cannula system that you want. You can see a big bubble forming on the left, and likewise basically on the right-hand side, where the tunnel's already been created, you can then basically put your cannula in order to basically get your big bubble as well. And the rest of the surgery is similar to basically a normal DOF, where you basically do the stromatectomy and remove this from the surface. And one of the big things I've seen with this basic technique is obviously because you're doing much larger anterior surface graft, the visual acuity results are outstanding in the early post-operative period, and of course you can take your stitches out basically much faster. So you see some of the results basically very early on at 1 month basically post-operatively from these cases. Now I don't do it on all cases, so of course the case on the left-hand side with vascularization, I won't do a manual basically, I'll do a straight basically dog. On the right-hand side, obviously with no vascularization in the periphery, I'll basically do a femto talk, and this is our publication showing a whole series of cases where we pretty much do this basically for nearly everything that comes in the door. What we're doing new now is that we're doing this with high drops. This is a Pakistani lady that was sent to me from, came over with cross-linking in both eyes, had a cute high drops on the left-hand side, and you can see this on the video over here, where you can see the scar all the way down. So what I do is I use the same approach for the femtosecond lasers. You can see the scar all the way down to decimated membrane. So we program basically the mushroom configuration, but here now, of course, I take off the tunnel, that I can fire the laser within 100 microns of basically decimated membrane. You can see the cut basically all the way around. Once basically the lasers basically acquired the image, I know exactly basically where the scar is, and then we will do a standard basically mushroom configuration. And then what I'll do is that similar to as Vincenzo showed, I'll use a peeling off technique to basically take off that central area, in that central area of where the scarring is, to basically get as deep as possible, and then basically do the dog. So you see over here with lasers already basically cut. So once it's cut on the surface, you can see that basically the laser cut basically with the emphysema on the surface there. We will then go back and peel the donor. So the donor is prepared in an artificial anterior chamber maintainer, obviously matching the mushroom configuration, and you simply just peel off the anterior surface. Okay, and then what you do is you switch techniques now. You do basically a manual basically technique, just in that central 6.5 millimeter area. So there's no need to dissect out like we used to do in the past, 7.75 or 8 millimeters area itself. And this obviously will reduce your risk of basically getting perforation, because I'm only dissecting in that straight area. This is a marginal dissector that we use, which is a very nice blunt instrument on the surface. So basically once this is peeled off, you can then basically put your donor in and basically switch to this in the normal way itself. Okay, this is basically her outcome. I saw at 6 weeks post she was 6'9", corrected. She came through all the way back to important for me to remove any stitches. I told her I didn't know which stitches to remove because the vision was actually so good. So then I sent her basically back, and now she's basically been followed up in Pakistan. So in summary, the distinct advantage of using intraoperative OCT guided femto-assisted dog is basically giving you real-time information and obviously low energy concept with the laser. It's high level of basically safety and high level of efficacy. We have a 95% bubble formation in all our cases, and you get faster rehabilitation from the anterior surface. And a lot of these cases now I do under local anesthetic. This is a lady with NPC type 4. You can see in that picture both her eyes are done with mushrooms, both done under local anesthetic. She has cardiovascular risk factors as well. Downside, of course, you need a laser system, but now these lasers are basically quite available in many cases. Obviously, you can still perforate on instrumentally, so you still need to understand how to basically do it. Now, the calculations take a little bit of time, and obviously we're flat applanating now. That's where you can see those curves on decimated membrane, but in the future, hopefully, we're using liquid applanated systems. Thank you for your attention.
Thank you so much. I think, and we'll maybe have one question or one comment from the panel. Did you have a comment?
I'm curious to know, do you ever have cases where the femto will not penetrate through the pathology because it's so dense?
So you can, I mean, you saw that scar with that was a post-infectious keratitis case. In the scarring, because of the ZA, I can adjust basically the lamella parameters so I can increase, and that's actually the laser to cut through a pathogen. So I do torsion with that.
You always use the same
Yeah,
femto?
so we use the same femto. So you have to use the laser that works on a plasma-based system in order to cut through the opacity. But you can see that, to be fair, when I peel back with the left hand, I use the Sinski to gently sort of, let's just say, encourage the plane, but the plane is already there. I'm just basically peeling back a little bit hard on the left hand with the Sinski in order to remove the scar.
Thank you so much. Such an elegant technique. The next talk is by Dr. Caterina Sarnicola, Dolph peeling off original technique and spiral modification.
Hello, good evening. Waiting for my slides. Okay, perfect. So let's talk about the peeling off. Among the several dark techniques that have been described, peeling off is one of the oldest. But as other manual techniques struggle to spread at the beginning. One of the main concerns about manual dark is how to achieve a good visual outcome. And now we know that to achieve comparable visual outcome to big bubble or PK, we have to achieve a residual bed thickness less than 80 microns and uniform thickness. And the beauty of the peeling off is that you always achieve these results. So that's why it has become one of our favorite dark technique. So it was first described by Malbrun in 1966, and he showed this video during a previous SICSSO meeting. In the original technique, he was using sharp instruments to create a deep track among the trepanation group, and then he helped the peeling with the same sharp instruments. Over the years, this technique has become more popular. There have been several modifications, new names, new inventors, but we really believe that the name should remain peeling off in the honor of the original inventor. And now I'm going to show you how we're going to do the technique. This video because you can find unedited online, so if you're interested in learning this technique. So in this case, we tried with bubble that failed, so we switched to the peeling off. First of all, do a paracentesis, because when you're doing manual dark, you need to work with the soft eye. And then we use the same blunt spatula that we used to create the track for the big bubble, to create this track 360 degrees among the trepanation group. And we use it in a spiral fashion, meaning that we are trying to go deep and deeper until we are deep enough that we can just peel the tissue without using too much force. That means that we are very deep when the adhesion between the stroma lamellar has less resistance and we can peel the tissue. And as you can see here, the postoperative OCT, it looks like actually a big bubble postoperative OCT. So we review our first case series, but I'm going to show you the data of our latest publication about 10 years experience with peeling off. And over our 150 cases, the residual bed thickness was always less than 85 microns. And it was pachymetrically homogeneous except in 2 cases of really advanced keratoconus. Like in these cases with a really advanced keratoconus with extremely posterior elevation, we did an eventful bulk peeling off, and then if you look at the postoperative OCT, we have a thinner residual bed in the center, but it's thicker in the periphery. And probably that's because the keratoconus was so advanced that also affected the posterior stroma. So this is the second case, similar to the previous one, the really advanced keratoconus. In this case, we're doing the regular peeling off, like peeling the tissue, but we realized that there's still some tissue in the periphery. So remembering the previous case, we did another peeling, so we create a deeper track, 360 degrees. And then when we arrived at the point to peel the tissue, we had a kind of donut-shaped tissue because in the center the dissection was already deep. So here we are finished the second peeling, and here you see we have the peeling just in the periphery. And that's the residual bed thickness of very regular of this case. So that's something that you want to keep in mind when you have these really advanced keratoconus patients. And in 9 cases, we modified the technique. We use an assisted peeling off technique in case of previous eye drops or full thickness penetrating corneal wound. Like these cases, it's 16 years old young man that had a penetrating corneal wound 1 year prior and a traumatic cataract. So 1 year after suturing the cornea, we decided to do a dot. So we're working in the periphery, creating the track, of course the paracentesis again, but we cannot do the peeling because we are going to enlarge the rupture. So we actually were assisting the peeling with the sharp instruments because we don't want to stretch the tissue. In the area of the previous perforation, we have some leakage of the aqueous, but it's something that we can manage. We have just to complete the stromatectomy, try not to enlarge the rupture, and then we can put air in anterior chamber and suture the donor. And this is the 6 months follow-up. You can see the faint scar in the posterior stroma, but still a clear graft with no corneal edema. And 18 months after JALC, it was ready for the cataract surgery, and I'm going to skip the video here. We managed the astigmatism with the corneal incision, and we were very lucky because we were looking for a myopic results, but we got 20/20 uncorrected. That's not always the case, of course, but we can say for sure that this young guy has an excellent long-term graft survival thanks to a JALC instead of a PK. And in our experience, we just have one new decimated ruptures and no PK conversion with good visual results. So I really encourage you to try this technique because it's something that you want in your hands. We don't always have the chance to do the big bubble. Big bubble now remains indicated most for keratoconus patients, but for all the other indications, we have to be comfortable with the manual technique, and peeling off, I think it's one of the best. And this year, for the first time, we're going to have a course dedicating to the peeling off technique in AAO. We invite you to attend. Thank you all for your attention.
Any comments from the panel? It's really a lovely technique.
This is really beautifully done. So my question is that when you go down deeper to the layer, this is what we discussed for the live surgery, is that you peel it easier. So I think they give a guide like how deep you can go. Now that there is intraoperative OCT, what do you think about the role of using OCT to guide the depth? Of course, for the experienced surgeon, you don't need OCT, but for beginners, it might help.
Or if you have OCT, it can help you in many ways. So for sure, it can help you also understand if you're in the right plane. But most of us doesn't have it, or maybe not all the time in the surgery. So it's important that you can recognize the key points that you can tell that you're deep enough. One is that you feel less resistance moving forward your spatula. And the second, as we really see that beautifully before, you see this really shiny residual bed. That means that you're really, really deep, so you have to be more careful at that point because it's easier to perforate. And if you, at the beginning, if you just try to peel, if it doesn't come, go around away or another time.
I just have a question about, so you mentioned about hydrating the surface. So how often should you be doing that?
Very good question. So anytime that you see that the tissue is too much dry, you feel much more resistance, you dry and you wet it and you dry again because you need dry to wash, but you have to wet sometime to have a softer tissue.
I have a question. The size of the donor tissue?
It's the same size of the trepanation, yes.
Thank you.
Very interesting talk, both. I have a question for John, the maker. John, as you pointed out, we do mushroom as well. And I want to know exactly, are you 9/6 in terms of sizing, or what is your revelation size?
So, the average size of the anti is how much you want to a lot of my things go to Chinese, right? So we don't have big white. So I do minimum. So I do minimum in Chinese size about 8.5, 8.6. If I was in the UK, I'd be very much more aggressive and do 8.8, even 8.8, even 8.9 for the anti-cup. The stalk, however, I vary depending on whether it's a scar case or it's basically based on keratoconus. To be honest, I'll just do a 6 millimeter. But if you're doing 6 millimeter, I have to tell you, because it's flat applanation, you must make sure that your accuracy of your centration is accurate when you're doing the applanation. Or you can do 6.5. When you cut the donor, because I use dog grade tissue, so it's slightly more solid, I do a 0.1 oversize compared to what I cut on the recipient. So the 0.1, so 6.6 or something, or basically 0.1. So we do a 0.1 oversize. But if you want to get the refractive advantages, you need to be a minimum of 8.5 or even more aggressive.
That's what we do. So the other advantage of mushroom is, of course, that you have a stronger boom because of scanning all around. And we all see this patient coming to our casualty sometimes, PK certain, but even dark, they have a big probe of the eye, and that's an organs having a mushroom shape that helps a lot.
Thank you for that lively discussion. Our next talk is by Dr. Severe Hanish. Middle segment surgery, pars plana assisted endothelial cardioplasty in the unicameral eye.
Thank you, Dr. Colby. Buongiorno. As you all know, this has been a big passion of mine for about four decades. We finally have a name for it, middle segment surgery, and I'll explain in a minute. This is my disclosure slide. And so the definition of middle segment surgery is it's a surgical approach involving entering the eye through the pars plana to address anterior segment surgical challenges. So this is no longer just the domain of the vitreoretinal surgeons. All of us can do it. As you all know, the pars plana in most people somewhere between 3.5 and 4 millimeters posterior to the limbus. And we like to enter the eye for many indications because it's an area that's basically avascular and easy to work through. But anterior segment surgeons have not usually approached the eye through the pars plana. In 2016, as you know, Shinyamani published his famous paper about scleral fixation of a 3-piece IOL with no sutures, and that changed the way we do things. But there are other indications to entering the eye through the pars plana than simply scleral fixation. So, to show what you can use it for. This is a patient with corneal edema and severe pseudophacodenesis. And what you see me doing here after a pars plana vitrectomy is I am basically delivering the IOL / capsular bag complex with a Summerings ring into the anterior chamber and doing a subtotal bisection of the IOL, removing it from the eye, and you can see that the capsule will follow. And then the beauty of having a infusion through the pars plana is you can deliver these Summerings ring fragments out of the eye by burping them out. This is after a vitrectomy, so that you don't risk having them fall into the vitreous cavity. Now, the classical Yamani technique of feeding the haptic of the IOL into a thin-walled, wide-bore 30-gauge needle, exteriorizing it through the sclera, about 2.5 millimeters posterior to the limbus. I think this is how we all do it. And we do it 180 degrees apart. It's important to be 180 degrees apart. And if the eye is a smaller eye, you may not want to push all that haptic back in, so you can trim the haptics, cauterize the ends, and push the ends back into the sclera while watching where the IOL optic ends up. Once you do that, you're done with the IOL part. Now you have to do the endothelial keratoplasty. But the beauty of this is you basically have a unicameral eye, and you can use infusion to prevent the endothelial graft from falling into the vitreous cavity, especially if you have a big pupil, right? So, and you can move the irrigation, the infusion, from the pars plana into the anterior chamber. And if you watch carefully here, for those of you who do this type of work, the bubble stays in the anterior chamber, whether it's air or a isoexpansile concentration of SF6. Here's another case. One-eye patient already has a sclerally fixated IOL, has a tube shunt, unicameral eye, damaged iris. So what I'm starting with is creating a 25-gauge sclerotomy to help me with the next steps. Once I have them in place, I will pull the graft slowly into the eye, constantly infusing into the vitreous. This has been vitrectomized. This way, I minimize the risk of the graft migrating into the vitreous cavity and the gas bubble migrating into the vitreous cavity. I noted here that the taco was folded with the smaller part of the taco anteriorly, and I couldn't flip it over. So this is a technique you may be familiar with, just bending a 30-gauge needle, two 30-gauge needles, and basically flipping the graft over so that it's in the right orientation, as you can see with the asymmetric letter, the S mark. Now once that is done, we're going to inject the gas into the eye. This is an isoexpansile concentration, about 18% of SF6 or 14% of C3F8. If you're not comfortable with that concentration, you can go less. I'm infusing into the vitreous cavity so that the gas doesn't migrate posteriorly. And if it's a DSEC, you do want tamponade, so as opposed to a DMEC where you don't need the tamponade. So basically what I do at this point so that I don't have to risk the gas migrating posteriorly. I unscrub, I finish my paperwork, I ask the anesthesiologist to bear with me as we continue to the course. Another example here, again, you have pars plana infusion. I'm injecting my gas, and I'm struggling with keeping the bubble. As you can see, it's starting to go posteriorly. So I'm going to suture the incisions. I'm going to keep infusing, injecting gas into the anterior chamber. The graft is in place, the gas is in place, and now, 15 minutes later, when I take the infusion cannula out, it doesn't matter that I don't have tamponade because I had 15 minutes of tamponade, and then you can close the conjunctiva any way you like, in this case with fibrin sealant. All right. Now, this is a patient with a PCI well, corneal edema. I thought it was going to be an easy DMAC, so I injected the graft in. I see that it's upside down, no problem. And I flip it over. Now it's in a taco configuration, but the chamber is flat and the pressure is 50. So I got a problem. Obviously, this could be a suprachoroidal effusion, or it could be aqueous misdirection. We're fortunate enough at Wills Eye Hospital to have either a retina fellow or a technician to come and do an ultrasound. There was no effusion, so we felt comfortable proceeding by putting a sclerotomy in, again, about 3.5 millimeters posterior to the limbus, and I'm just removing a very small amount of vitreous to end the aqueous misdirection, about 0.2 milliliters of fluid. Now I'm able to unscroll the graft, but the eye is too soft, so I'm going to use the same sclerotomy site to put some fluid in the eye, push the iris anteriorly to help me unscroll the graft completely before I inject my gas. Okay, so you'll see me there now unscrolling the graft successfully after using the pars plana to put some fluid in the eye. And now the bubble goes in and tamponade is achieved. All right. So there are a lot of indications to using the pars plana to the advantage of the anterior segment surgeon. But in the context of endothelial keroplasty, the big advantages are manipulating the PCI well if there's a comorbidity, and making sure that the graft doesn't migrate posteriorly. For those of you who have done this for many years, you know that's a reality, especially in an irregular pupil, and of course preventing the gas from migrating posteriorly. All of you who do this know that in a unicameral eye, you put the gas in, and then you go to check on them an hour later in the recovery room, patient gets up to go to the bathroom, and the gas is in the vitreous cavity. So if you want tamponade, you're not going to get it in that scenario. In DMAC, of course, you don't need the tamponade. Thank you very much for your attention.
Thank you for that great talk, and you know you've made it when it's the cover story on iNet, right? Comments from the panel? Barry?
Be kind to me, Barry.
No, I think it's amazing. And we still get a little pushback from our local retinal surgeons that want to make sure we're doing depression, we do our sclerotomies, and and get annoyed if there's an issue. So it's still a little bit challenging for all the places to adopt it. But you're right, we feel comfortable doing it, and you make it look so elegant. So you should be using these techniques.
So the classical argument by the VR colleagues, you're not trained to do a complete retina at the end of the case, as Dr. Lee asked. Can you treat tears if you identify them, and so on and so forth? Statistically, that has not been a problem, really. The VR colleague sees the patient before and after surgery, and rarely is that a problem. But what we are arguing here, it doesn't have to be an anterior segment surgeon or a posterior segment surgeon. We think a middle segment surgeon should be comfortable with all the aspects of this procedure. And we would love for our vitreoretinal colleagues to do these procedures while being respectful of the cornea, hint, hint, being respectful of the angle, hint, hint, being respectful of the iris, hint, hint, being respectful of the ciliary body, and most importantly, the refractive endpoint. Not just give me an IOL off the shelf, +3, -3 endpoint is okay. It's not okay. So doesn't matter who does the procedure, we just want it to be done right, and the endpoint is good results.
Very nice, elegantly done. So the question for the aqueous misdirection syndrome. So I had one when I did my first DMAC, and then what happened? So when I asked my retina colleague, I said, can I do a limited anti-vitrectomy or a posterior vitrectomy? He said, no, it had to be a complete vitrectomy. Why in your case you release a little bit of fluid, and what do you think about like the difference between these two approaches?
Sophie, the big mistake you made was ask the retina psychologist. You know, for most of us who deal with aqueous misdirection, yes, it's ideal to maybe have a complete vitrectomy, but you really don't need that, you know. So there are many ways to deal with aqueous misdirection. It's not the topic of today's talk. You can create a PI with a limbus, you go in with a cutter, and the final analysis, all I was trying to do is to break the attack and to be able to form the chamber and tamponade the graft into position.
Yeah, exactly. Some of the malignant glaucoma can be broken by this atropine alone. So I think it really depends on the case, how to manage that.
This is intraoperative.
Yes, exactly.
So you can basically end the case and say, I'll come back on another day. I chose not.
Thank you. I think we need to just inviting the next one. That's a very great discussion, and thank you. But I think we need to move on. So I'm pleasure to continue with complex eye and unichamber eye. And I invite Alfonso Vasquez-Perez, one of my colleagues from Moorfields, to talk about DMAC in aphakia and annulitia, quite complex cases.
Thank you. Thank you very much, Vincenzo, and thank you, Dr. Sarnicola, for the invitation. Good afternoon, everyone. Yes, I'm going to talk to you about DMAC and aphakia, basically, and annulitis. We started on Moorfields actually a while ago. We have obviously volume of transplants, and I think for the last 5 years, we've been doing more than 1,000 transplants, and almost 500 then are DMACs, and we know that there's much less rejection with DMAC than DSEC, especially for complex cases. In our clinics, there's a lot of patients with corneal decompensation and comorbidities, and among them, obviously, we have patients with aphakia. So traditionally, or commonly until now, probably most commonly, we treat these patients with DSEC. And when you have a patient with aphakia and annulitia, there's always the concern that the graft may dislocate into the vitreous cavity, and it's been documented that it can produce retinal detachments. So, but anyway, so once you manage successfully to do a DSEC in these cases, it depends then on how much risk of rejection is, right? And the other way to approach these cases is obviously to do a secondary IOL implantation and repair the iris with a prosthesis, or just suturing, but implanting a lens or suturing a lens in the sulcus, it creates a defect anterior chamber as well. It makes DMAC more complex. And why I still prefer DMAC? Because I'm doing DSECs in these cases. I was doing DSECs, and I did not have really a long-term survival in most of them. Like I said, this is one of my cases. I remember it's a young patient with trauma, and he was managing really well with a DSEC when he was functioning with a contact lens for aphakia, but after a year he rejected, and the second DMAC was even less than that. So the idea of using some kind of help to do DMAC in these cases came from my dear colleague actually and mentor Bruce Allen, and that was a while ago. He just mentioned this that the retinal surgeon was basically stole the idea of retinal surgeons using a proline suture to prevent the oil to migrate to the anterior chamber, but in this case, it's just to allow us to unfold the DMAC and also prevent the DMAC to go to the vitreous cavity. And that was published a few years ago. And that's the series of cases we completed during this time, a total of 20 cases, 6 done by Bruce and 14 done by myself. And you can see he started in 2019, I started the cases in 2020. And surprisingly, some of the patients were really achieving very good vision, especially with the contact lens wearing. But there's all sort of complex eyes and complex history, mostly trauma and complicated cataract surgery, and some of them glaucoma and chronic uveitis. So that's what I'm going to present in this our results. So how it's done? So before you open the eye, you need to pass the Crowley suture, right? And that Crowley suture will pass it, or that's my modified technique, 3 times horizontally and 5 times vertically, and it has to be a double-ended Crowley suture, just in case, because if you lost one needle, you still have the other one to complete. So it's a net, and then you open the eye. Why you need to keep the eye closed? Because once you open the eye and you want to pass the suture, the eye will collapse, and that hypotomy is quite dangerous. So I remove the failed disc in this case. Nowadays, all the cases I just put in the ring. That's what actually an advisor, my colleague here, Vincenzo, decides that really helps. And if you have to do a decimatorexis, it has to be done under air, and that's something that you need to be familiar with. You cannot do a decimatorexis under viscoelastic. And this is the most important part of the clinic, as always I teach my fellows, is the delivery of the graft. It has to be delivered already in the correct orientation over the net. And you have the advantage here that you have a pseudo shallow anterior chamber, so the graft will remain in that position. It's not a deep anterior chamber that makes things easy, right? Even though obviously this case is aphakic and aneuritic, the graft is in that space over the net. You don't have to put a lot of tension when you suture the net. It's just a normal tension. You don't want really tense suturing at the limbal plane. That's where we pass the needle. And as you can see, this is a real time opening the graft, which is already in a correct position. It's not difficult. And then you attach the graft. If you have problems and before insertion you have a tight screw, this is a maneuver I usually do. It's just to try to open the graft once in the recipient to make it into a double screw. So what is done in the double screw? The same. You know, this is a 3.0 and goiter injector. I find it more having better control with this injector than the 2.4, the smaller one, and it has to be delivered very slowly with a tapping, maneuver over the net. Already in the correct orientation. You have a double screw here. This is a patient with aphakia and a Carli-Valley lens. Carli-Valley lenses are very posterior, so this is still unicameralized and high risk of rejection as well. And that's the case done. So once you have done that, you complete that, you remove the suture. You don't longer need the suture. The graft is attached, and just don't forget to fill the eye with BSS, as Dr. Hanley was saying. If the vitreous cavity is already filled with fluid, you can then inject your air. It's more likely that the air will remain in the anterior chamber. So, after this time, a total of 20 patients, let's say that 65% of the grafts remained basically clear, and we have a failure of about 1/3 of the graft, 1/3 of the total patient need recovery, which is higher than the average, but it's something that we can manage. And this is the survival estimation in these cases, and you can see initially, the literature when we started doing this were not really good in terms of survival, but they were doing another type of technique, the pull through technique, and obviously manipulation of the graft was more pronounced than the technique that we are presenting here. The survival estimated is about, at 5 years, is over 60% compared to less than 20% at 2 years of the initial study. So I think this is something that it can help a certain type of patients. And as I mentioned to you, this is also we learn as we do it. So the cases we are having the failure of the graft is because of 2 combinations. It's glaucoma and chronic uveitis. Over the last 2 years and a half, 3 years, I have not included any of these cases for DMEC, and the results have been much better. This is one of my few of my cases. The first case is a photograph. The first photograph still clear. And we managed to get endothelial cell count in some of them. It's not possible sometimes to endothelial cell count in all of them, and the graft's still working. Obviously, we cannot do DMEX or anterior keratoplasty in all the cases. We are trying now a new alternative. We presented this as well, our study at Murphy's with the EndoArt, which is an artificial endothelial keratoplasty for more severe cases, which seems to be promising. So to finish, yes, this is a safety net technique I will encourage. Surgeons who have experience enough with DMEC and feel that they can perform this in these cases to try, but needs to have a very careful case selection, and you have to have a surgical planning. And you can stand this a high recovery rate, and the patients could do reasonably well. And thank you very much for your attention.
Thanks for showing us the next possible in these very complex cases. Any question from?
what's your protocol for removing the safety suture?
So you don't need the safety, the net suture once the graft is reasonably attached, and it is possible to tamponade the size. So if you leave it, part of the air or most of the air, when you try to tamponade, will go posteriorly. So at that moment, when the graft is attached with that kind of normal physiological pressure, I remove it. So it's more likely that the air bubble will come anteriorly. And there's no point to leave it as well, because the patient will feel it's not a buried knot in this case, and that makes any advantage of leaving it. You need it only to unfold the graft and attach the graft. The attachments in DMEC are usually partial, almost. So you can always rebubble it, but if you want to rebubble the patient, you need to take to the theater. You cannot rebubble this patient on this slit lamp. And what Dr. Hans was saying is true. So these patients leave the patient lying flat for at least 2 hours. Because the moment they sit in the slit lamp, all the air disappears. But if you put the patients back, lying flat, you come back out after 20 minutes, you still see the air again. So I always ask the patients to continue positioning.
I want to have a couple comments. First of all, beautifully done, the surgery. The first comment I have is the double squat. That is such elegant because in our center we do all these very complex case. 10 years ago we started to do a double squat. Makes things so much easier because the double squat make the graft half unfolded, so you don't have to open up the tie scroll. So it makes it much easier. The second question is the pressure management, because many of the eyes have glaucoma. What is your take on manage these pressures so that the vision can be preserved? So because in our center we also have a majority of patients have those end-stage glaucoma. Without a very proper air management, IOP management, this eye will become dangerous no matter how clear the graft is.
That's very, very good comment actually. For those who know, I also do keratoprosthesis. I do orthodontic keratoprosthesis, and I work in an interdisciplinary team which includes a VR surgeon and a glaucoma surgeon. And they also see patients on my clinic. There's always general rule that the glaucoma needs to be treated before you do the transplant. If the pressure is not controlled, the patient needs to be done first. And if you have the glaucoma after the transplant, if it's not treated, the graft will fail. It's just a question of time.
Thank you also. Is that correct? Because you found the result of the beautiful done by Professor Sarnicola.
Can you hear us, Vincenzo?
Yes, we can.
Great, thank you so much. So we have Professor Sarnicola that he just finished the surgery. Beautifully, you can see all the stitches. Prof, you want to say something?
Yes. I just want to say thank you for your attention. The surgery was not like typical peeling off. I was afraid to break everything because the tissue in the center part is really very, very thin and full of scar, but I was able to peel off the tissue. Tomorrow we will find the recipient bed very thin, I'm sure, and this will make the prognosis of recovery of vision very good. That's it. And why peeling off in this case? It is because I saw that we can be in trouble with the dissection, with big bubble. We don't know if the adhesion of the stroma with the predemeschematic layer can make a disaster, a bubble burst, and so I believe that peeling off technique has become more popular day by day, and it makes us the opportunity to make surgery in more or less all the cases. Thank you.
Thank you.
Bye.
Bye-bye. Now we continue here and the team from Portugal, we start with Dr. Stagler, so that later we talk about having a feeling of study.
He's he.
I love it. I love
It was a beautiful surgery, and thank you very much for the invitation to the organizing committee. And if I could have my slides.
How old was the patient? He was like young?
So I'm going to talk to you about DEX study, diabetes, and
general,
care
right?
policy study.
We do general?
No.
That's the slide you're supposed to start with.
Just for the...
What have we learned so far with DEX? As we all know, diabetes has really become an epidemic worldwide, and especially in the United States, where we have over 30 million Americans have diabetes. That's almost 10% of the population. And according to donor pool, diabetes rate is approaching 40%. And that's compared to 10 to 20% only a decade ago. So it's really climbing fast. And in 2014, one of the first scenarios in that coal mine to alert us to this potential problem was my prior fellow, Dr. Mark Reiner, who's now at the University of Iowa. And he found that if diabetic donors, it was more likely that the graft preparation would fail, would tear, or too sticky. And so we knew there was something different going on there. And with DMAC being a leading procedure in the United States for EK, and IBANs trying to avoid diabetic tissues, it's starting to cause constraints that would limit the DMAC tissue supply to just non-diabetic donors with high cell counts that could run into real tissue availability issues. And also on top of that, making people a little gun-shy from diabetic tissue was the CPTS results, which looked at the state and found a higher graft failure rate in diabetic tissues, as well as higher endothelial cell loss and higher graft attachment rate. And just wanted to point out the DEX study was recently awarded by JAMA Ophthalmology the Clinical Trial of the Year, which we're pretty proud of. I think it's well earned. This is the journal's highest recognition for clinical research, and it's a question that could have significant supply-side consequences. So can corneas from donors with diabetes be used successfully for DMAC, the most common keratoplasty in the U.S.? I also want to point out that that study achieved an amazing 96% follow-up rate with patients. And I want to congratulate Dr. Lass and Dr. Price, our study chairs, to this study, for really bringing us together. About 1,100 participants at 28 clinical sites, and with 46 surgeons and 13 eye banks. And the patients were low to moderate risk DMAC procedures, 95% of them pubes dystrophy. And it's really a nice generalizable answer to the question that can't really be answered by just one study, because we need to know nationwide does this apply if it's a different surgeon, different eye bank, different clinical sites. And in the end had over 1,400 DMAC procedures. So the existing evidence, we have DMAC prep failures. We know that that happens more often, and CPTS told us that to say we can have some higher failure rates, endothelial cell loss issues, and increased graft attachment. There are some other studies that have been done that were not really definitive. They're retrospective or secondary analyses. So it's really an important question to answer, because with 40% of donor corneas coming from diabetic donors, we need to know how well that tissue is going to perform. Prior studies suggested adverse effects, such as the CPTS, and many eye banks were already preferentially allocating non-diabetic tissue to their DMAC preparation, which is going to really strain tissue supply. And what we looked at is the DEX specific aims, diabetes impact on one-year graft success, and then also diabetes impact on cell loss, and looking at the severity of diabetes on DMAC outcomes. So there's a risk stratification score that has to deal with how much end organ damage is there. It's a 0 to 5 ranking. I also used post-mortem hemoglobin A1Cs and a skin biopsy. A skin biopsy is looking at advanced glycation end products and oxidative markers. These are signs of diabetic tissue damage. The main findings were really, it was a very successful procedure. Patients without and with diabetes had a 96 to 97% success rate, no matter which donor it was. And donor diabetes did not impact the cell loss. It was 28% in both groups. So nice and tight at 1 year. The only place that diabetes mattered is what Dr. Greiner had already reported, which was that patients with diabetes have a higher graft preparation failure rate of about 6%, and without diabetes, 2%. So if the preparation was successful, you could go ahead and use that tissue and expect that your clinical outcomes would be equivalent and not worry about the diabetic donor status. So diabetes does not impact graft success or any of the outcomes at 1 year or cell loss. And it was also interesting to me that most of the cell loss actually occurred at 1 month. It was right at 24% cell loss, and that only increased by another 4% till the end of the year. And DEX really changed the conversation from we think diabetic tissue might be inferior to prospective evidence shows equivalent DMEC outcomes. And only a large multi-center, multi-surgeon study could really provide a generalizable answer such as this. So there are still some questions that we'll be looking at with the 1-year data. Looking at donor diabetes severity, seeing if that impacts outcomes. Also looking at donor, recipient, and operative factors, and seeing if that impacts the graft success and cell loss. You know, if you have to flip the graft over multiple times, or it gets trapped in a wound, all that's been reported. Looking at factors that impact graft attachment and also graft rejection, and there'll be other ancillary studies looking at testing, such as can you use trypan blue right after preparing the graft to get a cell loss estimate there. And a few sonography analysis studies underway, as well as looking at the genetics, the TCF4 expansion positivity and graft outcome studies. And that's genetics of the graft. In the longer term data, we'll be looking at the genetics of the patient, the recipient, and the graft. And NEI has extended funding to do this longer term testing, and it's out to 3 and 5 years. And we anticipate about 750 patients will be re-enrolled for that longer study. We're one of the sites at Devers. It's been interesting to watch the data coming in. Looking at all the factors, including diabetic status and graft success out at 5 years. And then the new aim will be that genetic study will be done on both donor tissue and recipient. I'd like to acknowledge all the patients, the study coordinators, investigators, and eye banks at the National Eye Institute, and also acknowledge my family, who wonderfully always comes to me at a SICSSO meeting, and that was top of volcano in Italy. And Sicily.
Thank you very much. This is really great stuff and super data for us, all, not just for the US, because we're starting the usage of the graph, scientific way, congratulations on the prize as well. Any comment, any questions from the panel or guys in the audience? There's much to say about congratulating you because it's fantastic. I had a separate question, which is in terms of age in the US, do you have a markup when you choose a donor cornea for the neck?
Do we have a maximum?
Or minimum?
Our eye bank will take from, I like 40 to be my lowest tissues, because younger than 40 it's just harder to prep and harder to use in surgeries, too tight. Up to 80. Some people limit at 75, we've recently moved up to 80, and so far the results are equivalent.
Okay,
we've done as young as 21.
Yeah, we had a 21-year-old female donor. That was not a pleasant experience.
And there is some variation, because sometimes even 25 can unfold really easily, and you're surprised, wow. So perhaps, the next stage will be we've now understood that diabetes is, and try to identify factors that may be unfolding easier, and perhaps there's also a wider range of ages.
And what can impact that study is, it's a good point about the ages. If I have a patient who I know has a hyperdeep anterior chamber, I ask for graft tissue over 60. So I don't take my 40 to 80, I go 60 to 80. Yeah.
One quick question. You did one at 21 years old. Have you found a difference in terms of tissue preparation? Is it harder to peel from a younger donor than an older donor?
Harder to peel from a younger donor because they haven't laid down as much of the desmoid membranes as just left there. With only the fetal layer and a little adult.
Thank you. I don't think Mark needs any presentation whatsoever. If we're really discussing about DMEC, it's because of Mark, so I've started with an applause for Mark now, before his talk, and after, of course.
I haven't said a word, I got that applause, wonderful.
You can talk about DMEC though.
What's wonderful is I don't have to talk about the MEC, I can talk about another level of my life, which is penetrating chiroplasty. First, I'd like to thank the Sarnicolas for inviting me to this SICSSO meeting. This is the best meeting of the entire year, bar none, and I love to see this grow. All right, what I'd like to talk to you about tonight is extreme transplants. transplants that go out beyond the cornea limbus into the sclera. Now, these type of transplants are fairly rare. I've only done about 6 of them in the last 12 years. So this is a rare situation to do these type of transplants. And where do we do these kind of transplants? I do these type of transplants when I cannot do a standard penetrating or dowel size. If you've got so much pathology where it goes all the way to the limbus, and you are going to try and suture in a graft that's usual 8 or 8.5, and there's no thick cornea to do that, you're going to tear cornea, or your suture's not going to hold. And so a graft like this that has got ulcerations at multiple locations at the limbus, you can't do a standard graft. You have to do something different. Here's an example. This patient had multiple episodes of herpes simplex throughout his 40 years, and each episode left him with extremely thin cornea, especially not just centrally, but also in the periphery at the limbus area in multiple areas, which gave him 21 diopters of astigmatism. It's hard to correct that with glasses, and extremely thin areas. Some areas were as thin as 75 microns in the periphery. Or this patient is, I call it find the cornea. This is a patient that had a strep infection that was delayed getting in to see us. We put her on intensive fortified antibiotics. It was a strep, and we, after 3 days, had a perforation of the anterior segment, and we had to go and do surgery because now we were worried about an endophthalmitis occurring. So what do you do with a case like this where you can't really see the cornea at all? And you expect there'll be areas of thinning. She actually had a perforation in one area, but multiple areas of thinning. Well, one option, and one that's been done for 100 years, is do a full thickness, large penetrating keratoplasty. Cut out a 12 millimeter area, get in the sclera, and just plaster on a full thickness cornea. And even though you need to oversize that to try and keep the angle open, I would say that you cannot keep the open angle no matter how much you oversize it. And what happens is the iris will come up in the periphery, and it'll seal off the periphery. Now you get absolute glaucoma. You may have felt like you had a success with your penetrating keratoplasty, but in reality, you've doomed that eye to absolute glaucoma, and subsequent surgeries, and many of these go on to lose the eye or the vision from glaucoma. So you have to do something different. One thing I would suggest is that we don't do MIGS, we do MAGS. That's maximally invasive glaucoma surgery. And that's what this is about, maximally invasive glaucoma surgery. If you're a corneal surgeon, you do corneal surgery, but you have to keep glaucoma in mind. So the first option always, if you have healthy endothelium, go for a lamellar transplant. And even though you might have a perforation here or there while you're trying to do your dissection, a lamellar is always the best option, in my opinion, and Sarnicola's opinion, I'm sure. What happens if you have terrible endothelium? I don't think that the endothelium on that patient with the strep keratitis was in very good shape, and neither was the one that had the herpes simplex. We did cell counts on him before. So if you have a lamella, you can simply put it on top, and then you've got a wonderful large transplant that has solved the problem, and you oversize it, and you have got the native endothelium and death space to protect you from getting that angle closure. But if you don't have healthy endothelium, or you have severe scarring centrally that goes all the way down to the endothelium, then my option, I think, is a hybrid keratoplasty. And it's not a hybrid because of the donor. It's a hybrid because of the recipient bed. So the hybrid is we do a dowel for the periphery, and we do a penetrating keratoplasty for the center, and you do it all in one large transplant. The key on this is by creating a flange, and you can see on the bottom image there, that we created about a 100 micron flange, as thin as we can possibly get it, that will create and keep that space. If it's a very short flange, the iris will come up right at your junction, and it will plaster up just like a full PK. The flange has got to be longer than just a millimeter or so. And the final result, if you do this, is that flange will keep the angle open. This maximally invasive glaucoma surgery is going to keep that angle open and prevent the long-term glaucoma problems. The other key on this is to leave the endothelium completely intact over the entire 12, 13, or 14 millimeter graft. Leave the endothelium on completely, because those flange will probably be hanging in the anterior chamber until they eventually will seal up, opening up the angle even more for you. But that's the endothelium left on your large transplant will keep the cornea clear without bullae while the patient heals. So, surgical technique, first thing you want to do if you can is to save the surface limbal stem cells, because you need to get this large transplant covered again. So what I do is I take a 9.5, 10 millimeter tree fine, cut down about 100 microns in the periphery, and then I use a crescent blade to undermine the superficial tissue into the subconjunctival space, and then I simply retract the limbal stem cells in the conjunctiva as far back on the sclera as I can. It also helps you practice to be a retinal surgeon. And then I take a 11 millimeter tree fine, and or 12 or 13, whatever it takes to get outside the area of the infection or whatever, and I'll mark the area. And then I'll take my diamond knife, see the lower left-hand side, and I'll cut down as deep as I possibly can to make a very thin flange. I'll carry this out then with the crescent blade, and now create a total lamellar dissection. And if I can do that without perforation and there's healthy endothelium, then I can just do a lamellar transplant and oversize it by about 1 millimeter. Once I've got that lamellar dissection done, then I'll mark my central cornea with an 8 millimeter because I need to replace that defective endothelium. And I'll mark it and then simply go in and, like a normal transplant, fill the chamber with helon, enter the anterior chamber and cut that central 8 millimeters out, leaving that peripheral flange of tissue that's very thin. Once I've got that tissue taken off, I can do whatever I need to do in the anterior segment, provided it's uninfected. And I'll take and put on my large. This was an 11 millimeter tree fine, or dissection, and I put 12 millimeter full thickness on there. Then we place all the sutures on there, and then we pull the conjunctiva with all the limbal stem cells over on that area. Final result on a diagram is, like I said, you leave the endothelium over, everything's going to be nice and clear. And in this patient pre-op, this is post-op 1 day. We've covered the area with amniotic membrane to help with the healing. This is post-op day 13. You can see on that left-hand side the space between the graft itself and the flange that I've left there in the periphery. And you can see how clear it is at day 13. And the topography on this, the thermography, showed that it went from 21 diopters to 1.1 diopters of the astigmatism, and the coronal thickness is 450, 490, something like that. What about this case? This is a little more challenging than one before. But what we did with this case is first took a Wexo and wiped off all the necrotic material. You have to keep going? Oh, I can stop and just let you think about what we did on this one. But, okay,
go.
Okay, so we took the patient's surgery and did the same thing. Recessed the conjunctiva, did a 12 millimeter deep trepanation, did a lamellar dissection to get my posterior phalanges, and then did a full resection of the central area. We also cleaned out the anterior chamber and put a 13 millimeter graft surgery in place and pulled the conj back over. And here's the patient at 3 months out. Healthy epithelium, vision without glasses, 20/60. She had a cataract that we were going to take out later. No rejection. And because of the peripheral recipient flange, the angles were wide open. No iliacorneal adhesions in this case at all. The pressure was 16 on no glaucoma medications. And that's the key to this surgery, as you're looking not just at replacing the anterior cornea, but you're thinking about the angle and not giving them absolute glaucoma. So not a bad result to go from that to there in 3 months. The take-home points are basically that full thickness grafts destroy the angle, even if you try and vault them, if you're that far out on your replacement tissue. Large diameter hybrid transplant preserve the angle, and that's the point of doing this long surgery. I would like to say it only took an hour. It took 3.5 hours to do the surgery. Big question, what's the rejection rate going to be with these giant transplants? We've had one rejection of that, and we had to go in and do it to MEC underneath this large transplant to clear the cornea again. And can we use this technique? And I think this is what I want to pass on to you all, is can we do this for old keratoconus eyes? Eyes that are 25 years out from their penetrating keratoplasty in keratoconus, and yet you know what happens to that peripheral cornea. It gets thinner and thinner and thinner, and the edge starts to lift up. Why not try this technique on those eyes? We've done it once and it worked. So it takes a lot of work. And I'd like to thank Charlie, my sons Charlie and Nicholas, for staying home and allowing my wife Cindy and I to celebrate our 38th wedding anniversary today. And Cindy's going to join me
I just want to make give a tribute to Mark. Maybe this is out of line, but I want to thank you on behalf of the entire cornea community. I want to thank you on behalf of the entire cornea community for your dedication over more than 4 decades to our subspecialty, for changing it in a way that betters the lives of our patients irreversibly. And I'll take it. And most importantly, for doing this so unselfishly, meaning sharing knowledge without any return. I don't know anybody who's done that like you. So with great gratitude, thank you.
Are there any questions about the search?
Yes, great talk, Mark. The good thing is these are not very frequent cases, at least in my practice, and I've done a couple. But one thing about the flange, I agree with you. I've used anchoring sutures in those to kind of support that area. I'm not sure if it makes a difference or not, or if you have tried them.
What I did was put a bubble in there to try and push them up, but that was only on the second case. It really doesn't matter. They end up sticking into the anterior chamber because they're 100 microns, and that's still pretty stiff way out there. They don't fall down onto the iris. That's what I've learned on this. They will eventually attach 360 degrees to your overlying cornea, which opens up your angle even more, and you still have that massive amount of endosome.
Congratulations again for the legend in this field. I'm very impressed that you pay attention to nipple stem cells. And
I'm not a nipple surgeon. I love that.
Because you preserve the whole nipple stem cell, I think it might have prolonged the survival, increased survival of this graft. If without the stem cells, this graft going to get rejected and fell pretty prematurely. So I think this is one of the key points of my
Thank you.
We see quite a few designs in London, and most of them will be perforated by the time they come to surgery. So one issue that's difficult is to mark and then with free-end dissection. Do you have any tips for that? Because it's easy for some of us that are older, because I remember when I started doing PKP in London when I was 27, we would just mark and then free-end everything. But it's a skill that's difficult to teach. How do you do it? Do you use any?
It depends on the size of the perforation. Can you see the perforation?
Talking about very large graft, huge perforation.
Well, I still think that even if you have a perforation in one quadrant, you have these other quadrants that you have to remember are going to collapse if you are going to have no flange at all, and you'll get all that perphalangiosnekia. So if you have a perforation on one quadrant and you cannot do it's a large perforation. Small perforation, you work around it. Large ones, you create the flange in every other section you can. And even if you get closure of the angle in that one area because it's got no stroma there, you've got all the rest of the angle open for you. So I would encourage you that you still try and do a dissection. And if you can do a dissection on the gout after you've had perforation, and I saw all the time, you can do this. It's even easier because it's thicker tissue. Good question.
Mark, wonderful surgery and very important to maintain the angle. I think one technique is a minor variation of this is a kind of a split thickness tuck-in technique for keratoglobus eyes and things where it's extremely thin, and once you do the large trephination, you can kind of split the corneal lamella and then actually tuck the graft in there, and it may work for some of these other larger diameter grafts. Yeah, you can treat
And
stem cells too.
Rajesh Balkova sent me a wonderful picture of an eye he did 18 years ago, where he simply wiped off the epithelium off the keratoglobus and put a graft on top of that, and he was able to preserve the angle. And but he's a magnificent surgeon, so what are you going to do?
Well, thank you very much, Mark. I think it was wonderful for you to end this, and we're right on time. And we had a great afternoon, lovely surgery, many wonderful talks showing us how to deal with the most complex cases. Thank you, everyone. Have a good evening.
Very nice day.
Yeah, we're holding a
La señora, quedémonos acá, señora. ¿Ustedes quedaron que sí o no? Ah, la de quiratocorio. No, sabemos que va a estar aquí, ya la vi. ¿Esta no es la de quiratocorio, la que viene acá de California? La que viene acá es de misceláneos, está por la de va a estar también con la que están aquí, de la que se vamos por ahí. Igual yo intentando
She's on the wrong team. Just kind of came on myself. They're still in London. So high. It's so high. Hai saputo niente? Non hai saputo niente?
I came here, I came here and I saw the golf course really
I would love to. Anytime we have a golf course nearby.
Sì, lo volevo dire a Mark.
Hello, girls.
Nice to have you.
Thank you. No, thank you.
Are you gonna give tomorrow's lecture
For
also?
Professor Vincenzo. Yeah. That's no
Thank
problem.
you.
No
Thank
problem.
you
No
for
problem. He
doing
texted me.
that.
He was a bit sick
Our
or something.
savior.
He had I think he got food poisoning or something. And then
Yeah.
yesterday I was on a call and they said, John, do you know this? And I said, no. And then I texted him this morning and then I said, are you okay? And he said, yeah, he's feeling better. And I said, look, send you a talk. And then I saw,
happy to hear that.
I saw Francesco and then he said to me, John, can you do the thing? And I said, yeah. I said, I
Step
remember it was
in.
yesterday. So I said, it's okay.
Thank
yeah,
you
no
for doing
problem.
that.
No, I'll get it. I'll upload it tomorrow.
Yeah, tired.
Now, I don't have to recognize flags like I did last time. That was really difficult. You guys were put in a very awkward spot.
No talk.
Oh, thank you.
Just be there because you selected it and shake hands.
I will say
I learned.
congratulations.
Yeah. Be fine. Yeah, that's your job. Awesome.
I did very well. I could do it.
Pare che sia tutto rientrato. Sì, pare che sta bene. Ah no, qua è vuoto.
3.
E allora a che ora?
Scusa.
17:15.
Tra un po'.
E alla main room che c'è?
Ciao.
Aspetta, che ancora non ti ho fatto una bella foto. È bella, sì.
Ah, it's Caterina. Nice to see you.